All right, now that we've covered the anatomy of the lungs, we're going to talk about clinical pearls relevant to the lungs. All right, so we're going to start out talking about pneumonia. So pneumonia is an infection that inflames the alveoli within the lungs. So if you review, we have our trachea, branches off into our main bronchi. Then we have our lobar bronchi like this, and then our segmental bronchi like this, and it keeps branching down until you have these alveoli, which are these air-filled sacs where gas exchange happens. So if these become inflamed due to an infection, that's pneumonia, and that's caused by either bacteria or viruses. And it's usually contracted by either inhalation of aerosol drops containing the pathogen or aspiration of oropharyngeal contents, meaning inhalation of bacteria within the oral cavity and in the throat region. And so what this is common is people with dementia and severe alcoholics, because these, especially dementia patients, if they're lying around all day, they're lying recumbent, they're not active as active as a normal person. And then also dementia patients usually, along with severe alcoholics, they don't have as good of control over their swallowing ability. And so if you're not as in control of your swallowing, it's going to put you more at risk for aspiration, which would mean you have these this block of bacteria or a group of bacteria that gets, instead of swallowed into the esophagus, into the stomach, it ends up going down the wrong pipe, and hence going into the trachea, and then it makes its way into the lungs. And then it, as it makes its way deep into the lungs here, the bacteria colonize, and they cause inflammation and cause an infection, and that's how you would get what's called aspiration pneumonia. And in fact, the way you treat aspiration pneumonia is you give antibiotics that are more targeted at oral bacteria, because that's the bacteria that are causing it, versus other types of bacteria that would be inhaled from the air. So the presentation of pneumonia, you have sudden onset of high fever, productive cough, and chest pain. Basically, these people are sick as crap. They're in real bad shape, not feeling well at all, coughing a lot, chest pain. The gold standard for diagnosing them is you get a chest X-ray, and it often reveals either patchy infiltrates, which is kind of just patchy, on the X-ray, like patchy looking spots like this, or a lobar consolidation, which would be you see this on an X-ray, a nice mass of consolidation in one of the lobes of the lung, and that would be, for example, in your aspiration pneumonia, or if you have a colony of bacteria growing in one particular segment, that would be, your lobar consolidation. Your treatment is, especially bacterial, if it's you give antibiotics, which could be, you can give a fluoroquinolone, you can give ceftriaxone or a macrolide. If it's an aspiration pneumonia, so again, like I said, you want to treat the oral bacteria, you would give clindamycin for that. That's a very common board question. So now let's talk about pulmonary aspiration. It doesn't always cause pneumonia. You could have pulmonary aspiration at lunch today. You could drink some water, someone tells a funny joke, you start laughing, it goes down the wrong pipe, and then you're coughing up your food. So what pulmonary aspiration means is just it occurs when a solid or a liquid is breathed into the airways versus going into the esophagus. Because you remember, if you have the pharynx here, you have the esophagus, which goes this way, and then the trachea, which goes this way, if this is, posterior, anterior. So, you have your epiglottis here, which helps protect the trachea, but that doesn't always keep it closed off. So instead of things going this way, they go down this way and into the trachea. Examples, again, aspiration of oropharyngeal bacteria, aspiration pneumonia. You can aspirate liquid, food pieces, vomit. This is how people can die from vomiting, is that they're vomiting nonstop, they can't control it, and then they end up aspirating pieces of their vomit, and it goes into their lungs and affects their breathing, and it essentially ends up, if you get a large enough piece of vomit lodged in here, blocks out breathing, suffocates the person, they die. It's a very horrible and sad thing to think about, but that's how vomiting can kill somebody. It's through aspiration. Or you can aspirate stomach acid. So if someone has really bad GERD, gastroesophageal reflux, where you have stomach acid coming up into the esophagus, it can be so bad that where it actually can come up and then aspirate into the lungs, and then get sucked down into the lung tissue, causing a lot of damage to the lung tissues. The most common aspiration site is the superior segment of the lower lobe of the right lung. So you have the superior segment right here of the lower lobe of the right lung. The reason for that is that if you look at the trachea, so you have your left main bronchus like this, and then you have your right main bronchus like this, which we'll draw this here, it has a much wider diameter. It also has a much more vertical angle, so it makes it much easier for things to just go right in the right side. And so that's why when you aspirate things, they're much more likely to go into the right side of the lung versus the left, because you have this wider diameter, it's just more room, and then also the angle, it's a more vertical angle, which allows it to more easily just slide right into the right side. However, the position of the patient can determine the exact site in the lung where the aspirate will end up. And so here we have a nice table for that. This is something that could show up on an exam, maybe even potentially a board exam. So if the patient is standing or sitting upright, it will go into the posterior basal segment of the lower lobe of the right lung. So here's the lower lobe, and the posterior basal segment will be, in the posterior and then the base of the lung, so around right in here. Again, it comes down here, goes down here, in there. If they're supine, meaning they're lying down, it's going to be more of the superior segment because there's less gravity pulling them down. If they're standing or if they're sitting upright, there's more gravity in the way the lungs are positioned. There's more room for it to fall all the way to the basal or posterior part of the lobe. So if they're sitting, it's going to be more superior segment. And if they're lying on their right side, so that's going to be really, forcing the gravity, into this region, it's going to be potentially in the middle lobe or the posterior segment of the upper lobe of the right lung. So you can have the posterior segment of the upper lobe as well. So very briefly here to talk about obstructive versus restrictive lung disease. So we'll go through the main pathophysiological differences. So obstructive is airway obstruction. So if you look at, a segment of the bronchial tree like this, you have your lumen, you have your smooth muscle around like this, and then you have your lumen here. And so what happens is that, such as in asthma, you can get, constriction of the smooth muscle, you have gland secretion, so you're limiting the lumen. And what happens is the phase that's actually difficult for breathing obstruction is expiration, not inspiration. Because when you have to breathe out, it's much easier to breathe out against a wide open lumen versus if the lumen's nice and tight. And you could even, test this out. It's much easier to breathe, air out through, a large, cylinder versus, a straw. You have to put much more effort in. If you were to close your lips around a straw and breathe out air, it's much more difficult to do that versus if you're, blowing air out but through a much more larger cylinder. And that's because, it's much more resistance to airflow, and so it requires more effort. And so that's why it doesn't, the concept is the same. As the airway is obstructed, it doesn't matter. In asthma, it's, due to the muscle contraction. Emphysema, what happens is you have, your lung architecture like this. So you have your airway, and then you have these, pieces of connective tissue, areas of connective tissue and ultrastructure that separate out the lung. And you have emphysema, which is due to long-term heavy cigarette smoking. This gets all trash, and so it's just a big bag that easily collapses on itself. So in emphysema patients, the airways easily collapse on themselves. And so if the airways are collapsing, again, it doesn't matter what is causing it. If they're collapsing either due to muscle contraction or in the case of emphysema that there's no support structure, either way, the lumen gets smaller and it makes it much more difficult to breathe air out. And this is what's called, chronic obstructive pulmonary disease, or COPD. Versus restricted lung disease is where, so if you have your lungs like this, you have disease that makes it much more difficult. So remember, the lungs expand out to help drive air in. If the tissue, what happens is really the tissue gets thicker and more, stiff, stiffer lungs, thicker lungs, and it makes this expansion much more difficult. Okay, so the lungs can't expand out as much, which if the lungs can't expand as much, it makes inspiration much more difficult. And the causes for this are pulmonary fibrosis and pneumoconiosis, and those are things you can read in much more detail in a pathology book or pathology lectures. But basically what these pathological processes do is they thicken up the lungs, because if you have your lungs like this, if they can go out this far versus if they could expand out this far, expanding out much further is going to allow much more air to come in versus if you're restricted. So those are the main pathological or physiological differences between obstructive and restrictive lung disease. So a pulmonary embolism is a very important thing to be aware of. It's high yield for anatomy exams, physiology exams, pathology exams, board exams, shelf exams, and then, any type of doctor should be aware of a pulmonary embolism, especially if you're a surgeon. You're always going to be thinking, if you're an internal medicine doctor, cardiologists treat pulmonary embolisms all the time. This is something that's very important to be aware of. It's a complication that no one wants to have happen to any of their patients. What it is it's a result of a clot. So you have a thrombus, just some basic vocabulary. So a thrombus is a clot that forms in a vessel, okay, and it stays there. So an example of a thrombus would be a myocardial infarction, a heart attack. So a thrombus would be a clot that breaks off in the coronary arteries and blocks coronary flow, and that causes a heart attack. Versus an embolus. So an embolus is you have a clot that forms in, say a femoral vein, okay? And then, so you have your femoral vein here, your iliacs here, and then your inferior vena cava like this. What happens is an embolus is a clot that forms, but it ends up breaking off, and it doesn't block the vessel that it forms in. It travels. Okay, another example is if you have your carotid artery, which is in your neck, which goes to supply the brain, is you can have a clot that forms in the carotid artery, and then it travels up through the internal carotid artery and into the brain and causes a stroke. So that's how someone can get a stroke without having a clot directly form in the brain. They can have a clot that forms in the carotid artery and travels up to the brain. So again, back to pulmonary embolism. So you have a clot that forms in a vein, and then it travels up through the inferior vena cava, and then it goes into the right side of the heart. And if you remember, the right side of the heart is what pumps blood into the pulmonary artery and then into the lungs. So what happens is this clot, it comes up through, goes into the heart, and then it gets pumped out. This clot, it travels a long way. It travels all the way from your legs up through your abdomen, up through your chest, and into your heart, and then it ends up into your lungs. And so what happens is it gets into the lungs, into the pulmonary artery. It can even be in the more distant pulmonary artery here. It doesn't matter. Or it can be, if it's a large enough one, these are usually instantly fatal. It gets caught in the pulmonary trunk, and they obstruct blood flow, as we talked about, to the lung tissue for gas exchange. And so, like we said here in the text, the majority of these clots, they originate from veins in the lower extremity, and then they would break off and travel up through the femoral vein, iliac vein, IVC, and then the right atrium, right ventricle, and then into the pulmonary artery here. This is why deep vein thrombosis, detecting those in people's legs is very important, because deep vein thrombosis, DVTs, would be these clots that form, or a thrombus a clot that forms in the lower extremity, and then what turns it into an embolus is when it breaks off and travels up, and that's what makes it into a pulmonary embolism. So that's why, preventing DVTs, putting people on anticoagulation therapy like heparin, warfarin, these types of drugs help. Preventing DVTs from happening helps indirectly prevent pulmonary embolism from happening. So it depends on the clot size, like we talked about earlier, but if it becomes lodged in the pulmonary, either in the pulmonary arteries here or the pulmonary trunk, it doesn't matter. Or if it's coming, the more proximal it gets lodged, meaning the more blood flow it's cutting off, the more potential it has for being lethal more immediately. So what also to remember here is that it does not lead to pulmonary ischemia. So it's not that you're cutting off blood flow per se. It's more so that it's the more strain you're putting on the heart. Because remember, the way a pulmonary embolism kills somebody, it's not like a heart attack where you block off blood flow and cause ischemia. It kills somebody because it causes instant, significant strain on the heart, especially on the right side of the heart, which is pumping blood directly to the lungs. By causing that significant right heart strain, it overworks the heart and causes it to fail and die, and that's what ends up killing somebody. And so it's not because of ischemia and tissue dying off in the lungs, because it has that dual blood supply provided by the bronchial arteries. Saddle embolus is a large embolus that lodges and almost takes the shape of the distal portion of the pulmonary trunk, and it extends from the pulmonary trunk into both arteries like this, and it'll be shaped like this. And you can see some great pictures on the internet if you do a Google search for it. And it includes the pulmonary arteries or the main branches, and like I said, it creates a sudden increase in pulmonary pressure, because if you have let's draw this here. So if you have the heart here, and you have the right side, and it's, you know, going up into here, and this is your pulmonary artery, and it's coming off of the right side of the heart. If you have a clot, huge clot that forms in here, that, you know, creates a sudden increase in pulmonary artery pressure. Okay, so it puts a lot more strain on the heart to pump blood flow. Again, it's, you know, pumping against an obstruction, and so what that does is, again, causes acute strain on the right ventricle, and it leads to sudden death. Now, how do you diagnose these? Usually to get a chest x-ray. A chest x-ray, honestly, isn't going to show you too much for the pulmonary embolism. Big thing you want to do is D-dimer. This is a test for clotting mechanisms occurring and helps you detect if there's clotting cascade is active. Again, the major test you want to get is either a VQ perfusion scan or a spiral CT. These will give you the most definitive diagnosis because it's going to give you a clear picture of the blood flow within the lungs, and that's what you're looking for, is blood flow within the lungs, and it'll show you if part of the blood flow is cut off. How do you treat these? You do anticoagulation therapy, so you want to bust this clot up and also prevent future clots from happening. So you give heparin, and then you can bridge, once you give them heparin for long enough, if you need to put them on long-term anticoagulation, you put them on warfarin therapy. Malignancy, so cancer of the lung. The lungs, just like the brain, the liver, many other major organs, the most common tumors that occur there are actually metastasis from cancers in other areas. But primary lung malignancies are carcinomas, meaning epithelial tumors, so they derive from epithelial cells, and they're divided into two major categories. When you're talking about lung cancer, you always want to distinguish if it's small cell carcinoma versus non-small cell carcinoma. There's a pathological difference, and then there's also a patient management difference. These are managed very differently because of the nature of the disease. The symptoms for lung cancer, they're very nonspecific. Sometimes they're totally asymptomatic, but often if someone comes in with symptoms, it's chronic cough, shortness of breath, chest pain. It can also include hemoptysis because of the tumors eating away at tissue, weight loss, some constitutional symptoms. The way you diagnose it is usually chest CT is going to give you the best picture. So you'll do a CT, which would look like this, axial CT, and unfortunately you'd see a mass within the lungs. To get the definitive diagnosis, you biopsy it. So you stick a needle in here and take a sample of the tumor. How you treat it, it's really like how you treat any other type of cancer. You can do surgery, radiation, chemotherapy, one of these, two of these, all three of these. Usually when you can do all three of these, that's when you get the best result. Lung cancer, unfortunately, is a pretty dismal outcome. Lung cancer is not something you want to have to get or deal with. All right, so physical exam of the lungs. We're not going to go over what physical exam maneuvers. What this really is to help you with question stems, helping you figure out what a question stem is telling you, either on your anatomy exam, on a board exam, a clinical exam. And so what we really want to give you is kind of a very quick and easy way to understand what do these mean. So when someone's bringing these up in a STEM, what are they really telling you? Now, in real life, it can be a little more complicated, but for your purposes, for exams, what we want to do is give you so that when you see these terms, you know exactly what they mean. Because this is not something that's always intuitive, or it's not something that's always taught, and so we want you to help you get as many questions right. So this can help you really get through question stems and figure out the diagnosis so you get the question right. So crackles, if you hear, they auscultate the lungs, it says in a question stem, they auscultate the lungs and they hear crackles in, any region, the right middle lobe or, the right lung. What this is often a sign of is pulmonary edema. So the crackles is caused by fluid. And so it's either pulmonary edema or fluid buildup. And so several different causes that you can have a pleural effusion, you can have pneumonia, you can have heart failure that's leading to pulmonary edema. So crackles, so if a patient comes in and they've been short of breath and they're waking up at night short of breath, these signs of, congestive heart failure. And so that, the heart is failing, and so fluid is blood flow is building back up into the lungs, and that's causing buildup of fluid in the lungs and congestion, pulmonary edema, fluid buildup, then that's going to give. So heart failure patients often have crackles on their pulmonary exam. Versus wheezes, these are a sign of lower respiratory tree obstruction. So this is the key thing here. Someone's wheezing, it's because they're obstruction. And so when does someone wheeze? During an asthma attack, for example. Sometimes, some asthma patients, even when they're just sitting there, you can hear some wheezes. The big thing you'll hear wheezes for is COPD, So often patients with COPD will have wheezing. So if you hear wheezing, you want to think obstruction in the airways, okay? In the distal, in the respiratory tree, not obstruction in the trachea, not obstruction in the main bronchi. It's more obstruction in these segments of the lungs, okay? That's what wheezing is. Obstruction in the upper airway or in the trachea, that's stridor. So that's that kind of whooshing sound, and this is a sign of upper airway obstruction. This would be something that, some little kid swallows a marble and it gets they aspirate and it gets lodged in here. That could be stridor. Another example of stridor is such as like a Haemophilus infection, which affects the upper airways and, creates a lot of inflammation and edema and narrows the airway, the upper airway, and gives you epiglottitis, which can also help, narrow the airway as well. Those are signs of stridor as well. So stridor can be an indication for a number of things. It can be aspiration, like we talked about. It can be epiglottitis, which is in, Haemophilus or other infections. And so it's really just an indication of upper airway obstruction. Percussion of the lungs, it can help you determine the nature of abnormal contents that develop in the lungs as a result of a pathological process. So what that means is it can help you localize, for example, a consolidation. So it's, a pneumonia or some other kind of collection of debris or tissue. So when you have resonant percussion, and you'll see this in question stems, if they tell you the patient has resonant percussion, what they're really telling you is that it's normal air-filled lungs. So they're basically telling you is the lungs, at least from a percussion standpoint, are normal. There's nothing, there's no fluid buildup, there's no consolidation, there's no air trapping. They're normal. They're moving air normally, okay? If it's dull to percussion, what they're telling you is that it's fluid or tissue debris that are filling up, and this can be due to either pleural effusion, or left-sided heart failure. So again, the heart is failing. You have, the blood backs up in the pulmonary veins, and then you have fluid that builds up in the lungs. Again, that gives you your crackles, like we talked about on the previous page. But it also can give you, if you have a certain area where there's a lot of fluid buildup, you can have, dullness to percussion over this area here. And that can give you an idea of where there's a lot of fluid buildup. Also, if you have a pleural effusion, which is, fluid building up in this pleural space. So if you do some percussion here, you can find where the pleural effusion is. Could also be due to debris or tissue that's infiltrated with white blood cells and bacteria, such as in pneumonia. So if you have a consolidation due to pneumonia, if you do percussion over this region, it can tell you that the consolidation is in this region of the area. So it can help you localize certain areas of abnormal tissue and also give you an indication of maybe what is exactly going on, whether it's some kind of fluid buildup, some kind of tissue buildup. So if it's, it's all about putting the whole thing together. So if someone comes in, they have a fever, they have a high white count, they have dullness for percussion over, the left upper lobe, then maybe they have a consolidation pneumonia in the upper lobe of the left lung. So you should get a chest x-ray and check it out. It's all about the clinical picture versus if someone, comes in short of breath, they're waking up at night gasping for air, they have, they've had 3 or 4 heart attacks, they've got heart disease, maybe they've in congestive heart failure and, they have fluid buildup. Hyperresonant percussion, this is air trapping, such as in emphysema or asthma, again, obstructive airways, so you by narrowing the airway, what you're also doing is, it's the same thing as, any other tube. So if you narrow it, you're going to have air build up, okay? So you're going to have an increase in air in certain parts of the lungs, so air trapping, and that occurs in, these processes, COPD, asthma, emphysema, so you have hyperresonant percussion. So again, someone comes in, they have trouble breathing air out, they're a long-time smoker, maybe they have emphysema, COPD, you do some percussion, they have hyperresonant percussion. Again, helps support your diagnosis of COPD. And that concludes our discussion of the pulmonary clinical pearls.